Welcome to the Cytokine Signaling Forum series of highlights from ACR 2021, where authors take us through their posters and presentations on cytokine signaling and JAK inhibitors. My name is Len Calabrese, and I'm the head of the Cleveland Clinic section of clinical immunology. In this edition of our ACR highlights, we focus on the selection of presentations that deal with clinical outcomes from rheumatoid arthritis trials, including the important topic of switching between therapies.
Hello, I'm Dr. Janet Pope. I'm a professor of medicine at Western University in London, Ontario, Canada. This is poster 814 from the ACR 2021, and thank you for stopping by. So my poster was about patient characteristics, including efficacy and treatment patterns of tofacitinib as monotherapy in patients with rheumatoid arthritis. And what we wanted to do was compare the data from randomized controlled trials to what's been published or presented in real world data. So we could kind of contextualize, compare and contrast, and maybe have a take home message for people. So I was the first author. And as you can see, there were several authors, particularly from Europe on this poster. And this was funded, the work by Pfizer to look at tofacitinib, and they did have the real world data. So what did we do first? Well, we wanted to really look at monotherapy studies of randomized controlled trials with tofacitinib, and then compare by a literature search of real world data. And the methods were to do a systematic review of basically any real world data of tofacitinib, and we were already aware of the trials of monotherapy within the clinical trial program. When we did make comparisons, I think number one, we found that there were data gaps. So the first thing comparing was, well, what would the efficacy be like? And in general, on what's been published to date, the lines of therapy are far different. So in the monotherapy clinical trial program of tofacitinib, in general, they were methotrexate or CSD-MART IRs. When you look at real world data, the vast majority of the patients were actually TNF or bio-DMARD IR in the real world. So if we're going to compare monotherapy and an earlier line of therapy, we might find differences. By that, I mean, you could find differences potentially in effectiveness versus efficacy, depending on real world versus the clinical trials. You can find differences in retention as well. So when we looked down at figure one, you can see here looking at different groups of patients. The cohorts were really divided into the line of therapy, as well as looking at the randomized controlled trials. And you can see here that real world data probably performs the same if you're in the same line of therapy as what we would find in randomized controlled trials. We also, though, had different groups of patients. So as for instance, one of the randomized controlled trials was looking at a special population. So these were patients, as for instance, from Japan. And so the performance might be different because the dose metabolism might be different. But I think what's most important about this poster is that when a drug comes to market, in general, there will be data gaps, and real world data can help us. Also, in general, when a drug comes to market, it will depend on access, and it will also depend on prescription patterns. As for instance, when we first get access to a medication, we might use it in later line of therapy, such as after a TNF or other bio-DMARDs. And then over time, although our poster didn't look at this, others have shown certainly that over time, patients with less high disease activity and earlier lines of therapy often will then have the usage. So I think we can conclude that patients with tofacitinib monotherapy in the real world are different than patients in randomized controlled trials, because monotherapy use in the real world is now about 50% of tofacitinib Whereas in the whole clinical trial outcomes in tofacitinib, it wasn't that high, and it is increasing, it looks like, over time in some of the databases. We can also conclude that it's difficult to understand durability or retention in the real world because of the fact that we really don't know the confounding. Sometimes they're only looking at the first year of treatment, whereas to really know durability, you have to follow for many years. And I think we can also conclude that there are also similarities. So in general, the patient population of RA with very prevalent disease, failing CS-DMARDs, that we can expect about the same results in the real world. So when I go back to my practice and think about this, I think that really on any of the JAK inhibitors, as they come to market in different, I guess, mature markets throughout the world, and as newer ones come, that we're going to see practice patterns shifting. We're going to see practice patterns shifting as well because of some of the safety data and recommendations that we've received from our own health authorities. So I think that this gives you an idea that when we look at real world data, it depends on the year you look. There will be differences because we introduce in earlier lines of therapy or less severe patients over time. So I hope you enjoy the ACR, and thanks for attending.
It's a pleasure to talk to you. Thanks for your interest in our poster. And on behalf of my co-authors, I would like to present the results to you. The question that we are looking at is whether there is consistency or not with regard to the response on introducing upadacitinib in patients with varying background therapies. And we are looking at 4 of the phase 3 clinical trials and select choice, including patients who had previously failed to biologic DMARDs. Select next and select monotherapy included patients who failed to conventional DMARD therapy, and select monotherapy patients who failed to methotrexate. Not surprisingly, disease duration would be shorter in the groups of patients who did not have previous biologics. That's a little bit of the background. Looking at this patient population, the question is, which responses are we going to look at? And figure 1 shows to you the time to first achievement of DAS28 CRP equal or lower than 3.2, meaning DAS28 CRP low disease activity. And we are comparing patients on upadacitinib, so no comparisons to adalimumab or to abatacept. But the point is that you can see that regardless of which patient population you look at, the time until 50% of the patients have achieved the respective response. In this case, the low disease activity is pretty much similar. If you look at figure 2, this time we are looking at the time to first achievement of CDAI low disease activity across studies. Why is this important? Upadacitinib is a JAK1 inhibitor that may interfere with IL-6 signaling. So theoretically, there would be an independent impact on CRP. So you probably would, if you do the calculation, think, well, the drug is working better than a clinical C. So using the CDAI tells you that this is without the CRP, and you see in figure 2, it is pretty much still the same. There seems to be a tendency for patients in Select Beyond. Those are the patients who failed to previous biological DMARDs. Maybe also a little bit with regard to select monotherapy, but I think overall there is no disadvantage for the patients who have a longer disease duration, you have a longer history of previous drugs, and that's mainly the key message that we try to communicate in this poster. Thank you very much.
So welcome everyone. My name is Thorsten Witte. I'm a rheumatologist from Germany, and it's my pleasure now to present you our data on the persistence on JAK inhibitors in daily practice in Germany. Now, as you all know, we can treat RA patients after the failure of conventional DMARDs with either a biological DMARD or a JAK inhibitor. Now, in our analysis, we wanted to compare the persistence of RA patients on TNF inhibitors, on non-TNF biologicals, and on JAK inhibitors. And we use data of the German RADA registry, which is obtained by 22 rheumatologists in private practice mostly in southern Germany and Bavaria. 5,166 RA patients have been documented in this registry after 2017. Prescription information was available of 4,726 of these patients at database closure. Now, out of these patients, 77% were female, their mean age was 66 years, and 60% were seropositive. Out of these 4,726 patients, 15.2% were treated with a new TNF inhibitor after 2017, 8.9% with a non-TNF biological DMARD, and 9.9% with a JAK inhibitor, and the persistence on these various drug principles was compared thereafter. Now, as you can see in table 1 on the poster, the patients on TNF inhibitors tended to be a bit younger, and they tended to have a shorter disease duration than the other groups. And most of them had actually been bio-naive before they were treated with the TNF inhibitors. The patients on JAK inhibitors were very frequently treated in monotherapy, almost 2/3 of them actually. Now in figure 1, you can already see the main results of our observations. And the main result was that the persistence on JAK inhibitors, TNF inhibitors, and on other biological DMARDs was remarkably high. In fact, higher than 85% after 24 months, which is higher than in most other observations from the real world so far. This persistence did not differ significantly between JAK inhibitors and TNF inhibitors, but was somewhat higher on non-TNF biological DMARDs. Now, in conclusion, to me at least, the biggest surprise in our study was the high persistence on any of these drug principles, whereas there was no major difference between persistence on JAK inhibitors or TNF inhibitors. And with this, I would like to thank you for your attention, and I wish you a very good day. Goodbye.
Hello, my name is Mikkel Østergaard. I'm a rheumatologist from Rigshospitalet and University of Copenhagen in Denmark. And it's my pleasure on behalf of my co-authors to present this study titled Effect of Tofacitinib on Spinal Vertebral Body and Posterolateral Element Inflammation and Structural Lesions using the Canada-Denmark MRI scoring system in patients with ankylosing spondylitis. Results from a phase 2 study. The aim of this study is to investigate the effect of JAK inhibition by tofacitinib on MRI-determined spinal inflammation, both in vertebral bodies and in the posterolateral parts of the spine, using the Canada-Denmark or the CanDen scoring systems in patients with treatment-naive ankylosing spondylitis. We hope that you will find the results interesting. This report describes MRI findings of 137 ankylosing spondylitis patients, all being biologically naive, who had entered a randomized double-blind placebo-controlled study, receiving either tofacitinib 10 mg twice daily, tofacitinib 5 mg twice daily, or placebo. And spine MRI assessments were performed at baseline and week 12. MRIs of the spine were read by 2 independent readers who are expert readers and have been part of developing the scoring system, blinded to time point and treatment. Discrepancies between the readers were adjudicated by a third reader, an experienced musculoskeletal radiologist. While other frequently used scoring systems focus on vertebral body inflammation, the scoring system applied in this study was, as mentioned, the Canada-Denmark scoring system, and this allows for a detailed anatomy-based evaluation of inflammatory and structural lesions in spinal vertebral bodies, as the others also do, but also in the posterolateral elements of the spine, including, for instance, costovertebral joints, facet joints, and the transverse and spinous processes and soft tissues. And this is important because these structures are frequently involved in ankylosing spondylitis. If you look in the poster, table 1, you'll find the baseline Canada-Denmark scores, which were overall well balanced, except for a slight variation in the FAT scores. But the inflammatory scores were very well balanced between the groups. Figures 1 and 2, they illustrate the main results. and they show significantly greater reductions in total spinal inflammation score. That's in figure 1A. And if you look at that, you see figure 1A with the 4 columns, and in all the in the 2 tofacitinib groups, both 5 milligrams and 10 milligrams, and the pool tofacitinib group, which is the red one, you'll see reductions in the score of something like 6 score points, and you can see the different groups there. While in the placebo group, there was no change, almost actually an increase in the score of 0.28, which is, you could say, more or less nothing. In contrast, the fat changes, as you see on the 1B, there were slightly higher increase in the active groups, but that was not anyway near to being statistically significant, so there were no difference there. In figure 2, you see the inflammation subscores. And that is one of the interesting aspects of this study. You'll both see in A, the vertebral body inflammation, in B, the overall posterior element inflammatory subscores, and also facet joints, corner inflammation subscores, non-corner inflammation subscores, and posterolateral inflammation subscores. And these are looking into the different posterior elements which are not captured by the other scoring methods. And what you will see is that in these, there are also significant changes in favor of the tofacitinib groups compared to the placebo group. So with this study is the first one to show that JAK inhibition with tofacitinib not only reduces vertebral body inflammation, but also inflammation in the clinically important synovial facet joints and costovertebral joints, and in the entices attaching to the transverse and spinous processes. By revealing such marked differences within just 12 weeks of therapy, the study also illustrates the high sensitivity to change and discriminatory ability of the Candin scoring system. We also looked into the reproducibility, which is not shown in the poster, but was very high between the 2 readers. So in conclusion, tofacitinib treatment in biological naive patients with ankylosing spondylitis was associated with significant reductions in MRI spinal inflammation as assessed by the Canada-Denmark MRI scoring system. Particularly, tofacitinib reduced inflammation in the posterolateral elements of the spine, such as facet joints, which has not been described previously. Tofacitinib was also associated with a numerically higher but non-significant and non-dose-dependent increase in total spine fat score. Thank you for your attention.
I would like to thank you for this opportunity to present the study. I am Dr. Pombo Suarez, rheumatologist working at Santiago de Compostela University Hospital, an assessor of BioBadacer, the Spanish Society of Rheumatology Registry of Biologic Therapies. The study we're going to talk about is focused on patients who have failed therapy with the first JAK inhibitor. We try to determine which would be the best treatment option in this scenario, either to use a different JAK inhibitor or to switch to a biologic DMARD. The 2019 update of the EULAR recommendations for the management of rheumatoid arthritis state that patients that have failed therapy with biologic or JAK inhibitor should be treated with another biologic or JAK inhibitor. At the time of the elaboration of these recommendations, no data were available of studies using a second JAK inhibitor after failure to a JAK inhibitor, and much less comparing both alternatives after JAK inhibitor failure, either to use another JAK inhibitor or to switch to a biologic DMARD. So that is what we address in this study. We try to shed a light in this growing population of patients as prescription of these drugs is increasing and new JAK inhibitors come into play, meaning that the scenario we pose is becoming more and more frequent in real life. The primary objective of the study was to compare the effectiveness of using a second JAK inhibitor versus a biologic DMARD in real-life patients who have failed therapy to a first JAK inhibitor. To assess effectiveness, we measured drug retention and disease activity with the DAS28 index. Secondary objective of the study was to evaluate differences in response to a second JAK inhibitor or to a biologic DMAT, depending on the reason for stopping the first JAK inhibitor. To achieve these objectives, to have enough sample size, we use the JACPOT study. JACPOT study is a collaboration of national registries from all over the world, registries that recruit rheumatoid arthritis patients being treated in real life with JAK inhibitors and biologics. It is directed by Professor Flint's group located in Geneva, Switzerland, and 14 countries participated in this particular project. We pull data from these registries coming from rheumatoid arthritis patients that failed to JAK inhibitor therapy and were subsequently being treated with a JAK inhibitor or a biologic. To determine effectiveness, drug survival was illustrated by Kaplan-Meier, and differences in retention were assessed with Cox regression analysis. We also determined the DAS28 evolution over time with a linear mixed model, imputing data for missing values. With this approach, we were able to collect more than 700 patients that failed treatment with JAK inhibitor, of which 154 were cyclers and 554 were switchers. We detected differences in baseline characteristics between both groups of patients. JAK inhibitor cyclers were older, had longer disease duration, received a higher number of previous biologics, and had longer exposure to first JAK inhibitor treatment when compared with switchers to biologics, meaning that JAK inhibitor cyclers had a more difficult to treat profile. Monotherapy was more prevalent among cyclers, and we also detected differences on both groups depending on the reason of stopping the first JAK inhibitor. If JAK inhibitor was stopped due to security, patients were more likely to cycle JAK inhibitors, whereas if discontinuation was because of lack of efficacy, a trend towards switching to biologic was detected. To assess effectiveness, drug retention was determined after 2 years of follow-up, and no difference was detected between both groups using Cox regression analysis adjusting for confounders. We also determined survival depending on the reason for stopping the first JAK inhibitor. If it was stopped due to lack of efficacy, no difference in retention was detected between strategies. In this scenario, we also analyzed the reason for stopping the second line of treatment, and we found that in both cases, most of the patients would stop also for lack of efficacy. If the reason for stopping the first JAK inhibitor was security, we did not detect significant difference in survival between groups either, although it seemed to be a trend during the first year of follow-up where discontinuation was more likely in patients cycling JAK inhibitors. Precisely, in this group of patients, the reason for stopping the second JAK inhibitor was also due to an adverse event in most cases, whereas in switchers, more variability was detected. DAS28 over time evolved in a similar way in both groups, with improvement in both cases after more than 6 months of follow-up. Of course, we must consider the limitations of the study. Heterogeneity between data coming from different registries could not be assessed due to the small sample size contributed by each country. Most of the patients received tofacitinib as first JAK inhibitor as well. It will be interesting to see what happens in both directions, going from tofacitinib to baricitinib and vice versa, as well as to include the newer JAK inhibitors in future studies. Another limitation of the study was the short follow-up. JAK inhibitors were recently approved, so the follow-up of the second line of treatment was not long enough in some cases, having to deal with the problem of missing data. To conclude, after failing a first JAK inhibitor, cycling JAK inhibitors versus switching to a biologic appear to have similar effectiveness, despite a more difficult to treat patient profile for the patient cycling JAK inhibitors. Finally, when the first JAK inhibitor was stopped due to an adverse event, it was more likely that the second JAK inhibitor would also be stopped for an adverse event. Finally, I would like to thank each of the registries that participated in this project and their representatives. Delphine Corbusier for her great effort processing the data, Professor Finch for leading the JACPOT study, and a special mention to Professor Gomez Reino. Thank you very much.
Hello, I'm Ronald van Vollenhoven, a rheumatologist and head of the Department of Rheumatology and Clinical Immunology at the Amsterdam UMC in Amsterdam, the Netherlands. And today I would like to share with you some results that I had the pleasure of presenting at the 2021 ACR Convergence Congress that took place digitally, and where a lot of exciting new data from the field of rheumatology were, of course, discussed. And on behalf of a group of investigators, I was in the position of presenting data on upadacitinib. And upadacitinib is, of course, a JAK inhibitor that is approved for the treatment of rheumatoid arthritis. And the analysis that I had presented here was one that was based on a clinical trial called the Select Early trial. And the question was, how about the long-term results? So first, a little bit about this particular trial. As you know, upadacitinib was approved based on a whole number of very large clinical trials, and one of those was called Select Early. And that one was a little bit unusual because it was done in patients who hadn't really been treated yet. I mean, they could have had methotrexate for a short time or maybe another conventional DMARD, but many patients were really at the beginning of their treatment trajectory for rheumatoid arthritis. And they were randomized to receive methotrexate, which is, of course, the standard treatment for newly diagnosed rheumatoid arthritis, or upadacitinib. And in this trial, there were two different dosages, 15 or 30 milligram daily. Now, as you know, 15 milligram is the approved dosage, so I'll focus mostly on that dosage. But it was interesting that this was a head-to-head between methotrexate and upadacitinib monotherapy. So it was interesting to see what would happen, and we were able to publish the results of that first analysis. We were able to show that the patients generally were able to stay in the trial and followed the protocol correctly, and that after a year of treatment, or even after a half year of treatment, there were already big differences in the outcomes. And I think there were outcomes after 12 weeks, which were mandated by the FDA, showing clearly favorable results for upadacitinib over methotrexate. And the results that I find the most appealing, after 24 weeks of treatment, the proportion of patients who achieved a remission according to the DAS, perhaps not the best definition of remission, but still very good for the patient, that was achieved by only 1 in 5 patients on methotrexate and almost half the patients on upadacitinib. So a very big difference in favor of upadacitinib, and also clinically, I think, meaningful, and suggesting that here we see a head-to-head comparison with a clearly better efficacy for one of the two drugs. And as I mentioned, 15 and 30 milligram of upadacitinib were both tested. There was no real efficacy difference between those two dosages. So this has all been published in Arthritis and Rheumatology in 2000. So now for the ACR Congress, we looked into the longer-term results with these treatments. And so we had data now for 156 weeks, which if you calculate quickly is 3 years. And we were able to show that after that long period of time, the difference was still very clear in favor of upadacitinib over methotrexate. So for example, looking at the ACR 70 response, which is of course an excellent response, which is what we want, it is still about half the patients on upadacitinib who achieved it, and who had achieved it and maintained it for those 3 years. With methotrexate, it was a lower percentage, in this case, 29.3%. We also looked at various other outcomes, and we were mostly interested not so much in response as in the disease state. As the words of Professor Dugado from Paris many years ago, he said that it's good to be better, but it's better to be good. And good in rheumatoid arthritis is if you have low disease activity or a remission, and there are various definitions for this. And so we looked at all these definitions, and some are tougher, harder to meet, others are a little bit more lenient. If you, for example, look at low disease activity according to the DAS 28, then you achieve it by more than 50% with upadacitinib versus a bit over 30% with methotrexate. If you look at the Boolean remission, which is the toughest remission criterion we have, then it's achieved by only 16% on methotrexate and by around 30% of those patients who were given upadacitinib for those 3 years. And then with the other outcomes, you can see intermediate results. But for all outcomes, for all these state outcomes, saying the patient is doing well, for all of these, the pattern is the same. Methotrexate is good for some patients. Upadacitinib is better for more patients, and the 2 dosages of upadacitinib are equal. Now you can look at the time course, because for the patient, of course, it's all very nice that they are doing well after 3 years, but how long does it take to get there? And of course, for upadacitinib, we already know this also from clinical practice, it works pretty fast. So here also the onset of the efficacy is rapid and clearly much faster for upadacitinib than for methotrexate, which is an additional bonus. Now, none of the efficacy data can be taken separately from the safety data, because we always have to have this balance in the clinical treatment decisions. And this clinical trial allowed us to do a very comprehensive safety analysis, and we looked at various different side effects or adverse events, as they're called. And of course, if you know clinical trials, you know that an adverse event is anything that happens. So it doesn't have to be related to the drug. It could just be a coincidence, but it's just tallied, and you look for a difference between the 2 groups. And what we saw was that for many of the categories of adverse events, there were no differences. The ones that did show a difference that are important to highlight here is that herpes zoster did occur more frequently with upadacitinib than with methotrexate. We also saw that neutropenia, low white blood cell count, also occurred a little bit more frequently with upadacitinib than with methotrexate. And we saw the CPK elevation. Now that is a bit strange because there is no clinical correlate. We have seen this with all the JAK inhibitors in rheumatoid arthritis. CPK elevations have been reported. They're seen in some patients. They're usually not very high, and the patients do not have myositis, and there's no other obvious clinical consequence. So this has remained a little bit of a puzzle. We think it's some sort of direct effect, and we do not believe at this time that this is something that we have to worry about, but it is something that we have observed. So these were the 3 adverse events that were reported more frequently with upadacitinib than with methotrexate. What is important to note is that there were also quite a lot that were not more frequent with upadacitinib than with methotrexate. For example, general infections or serious infections. And also what many people have been worried about in rheumatoid arthritis with comorbidities, cardiovascular events. All of these seem to have been at the same level for methotrexate and upadacitinib, and this is also true for adjudicated venous thromboembolic events. So far, so good, very encouraging results, and the safety remains very acceptable, and certainly also no new findings in this trial. So I want to conclude this particular analysis by saying that upadacitinib as monotherapy showed sustained and clinically very meaningful responses, including remission, compared with methotrexate, and this through 156 weeks, through 3 years of treatment. On the balance, we saw an increased rate of some adverse events, including zoster, neutropenia, and CPK elevations, but there were no new risks. And so on the whole, the balance, efficacy to safety, remains very good for the treatment of rheumatoid arthritis with upadacitinib. Thank you very much.
I'm Dr. Grace Wright, a consultant rheumatologist in New York City, and I'm presenting on behalf of myself and my co-authors. The title of this poster is Impact of Race on the Efficacy and Safety of Tofacitinib in Patients with RA, a post-hoc analysis of phase 2, 3, and 3B4 clinical trials. So racial disparities in disease severity, physical function, pain, and treatment persistence and tolerance have been reported in patients with rheumatoid arthritis. However, there remains a paucity of data on differences between racial groups in response to advanced RA therapies, particularly Janus kinase or JAK inhibitors. Here we evaluated the impact of race on the efficacy and safety of tofacitinib in patients with rheumatoid arthritis. This post-hoc analysis pooled data from 8 phase 2, 6 phase 3, and 1 phase 3b4 randomized control trial. Patients received tofacitinib 5 or 10 milligrams twice daily, adalimumab 40 milligrams Q2 weekly, or placebo. Across all treatment arms, patients most commonly enrolled from Europe, North America, East and South Asia, as well as Latin America. Efficacy and safety outcomes were stratified by self-reported patient race and categorized as white, Black, Asian, and other. Most of the other patients self-reported as Hispanic and/or Latino, followed by mixed race and then unspecified. The analyses were as follows. Efficacy outcomes were analyzed at month 3, and this included ACR 20, ACR 50, ACR 70 response rates, CDAI, DAS28 ESR, low disease activity, and remission rates, respectively, and then least square mean change on the DAS28 ESR, as well as change in HAQ-DI. For binary outcomes, odd ratios and the 95% confidence interval for active treatment versus placebo were calculated using logistic regression models. For continuous outcomes, placebo-adjusted least square mean change, the 95% confidence intervals, were calculated using MMRM. Incidence rates, that is patients with events per 100 patient year, censored at day of first event or up to last dose plus 28 days, were evaluated for adverse events, serious adverse events, discontinuations due to adverse events, and all-cause mortality. Of the 6,355 patients included, patient self-reported race was 4,145 white, 213 Black, 1,348 Asian, and 649 other. Baseline characteristics were generally similar across treatment and racial groups, excepting higher rates of prior bio-DMARD exposure in white and Black compared to Asian and other patients. Across treatment arms, white, Black, Asian, and other patients most commonly enrolled from Europe, that's 40.9% with an N of 1,696, North America of 68.1% with an N of 145, and East and South Asia 97.9% with an N of 1,320, and Latin America 80.6% with an N of 523, respectively. Most of the patients, as I said, self-reported as Hispanic and/or Latino, followed by mixed race. At month 3, ACR 20, 50, 70, and CDAI low disease activity rates were mostly higher in other versus white patients treated with tofacitinib. DAS28 ESR low disease activity rates and least square mean change in the DAS28 ESR and change in HAQ-DI were generally comparable across racial groups with active treatment. Across efficacy outcomes, placebo responses observed in Black patients were generally numerically higher than those observed in white, Asian, and other patients. Our safety outcomes, which included the adverse events, serious adverse events, discontinuations due to adverse events, and all-cause mortality, were broadly similar across treatment arms, with higher adverse event incidence rates seen with Black and other versus white and Asian patients treated with tofacitinib. So in conclusion, across racial groups, tofacitinib efficacy and safety were consistent with previous findings from the tofacitinib RA clinical program. Higher ACR 20, 50, 70, and CDAI low disease activity rates in other versus white patients with tofacitinib may be attributable to prior treatment history and regional practice norms. Numerically higher placebo responses in Black versus white, Asian, and other patients with tofacitinib may reflect demographic differences, notably the country of enrollment across the racial groups in RCTs. Safety findings were generally consistent across racial and treatment groups, with some racial differences seen in adverse event incident rates seen with tofacitinib. So future analyses should focus on the impact of socioeconomic, cultural, genetic, or practice-based differences that may underpin these results.
Hello, I'm Ronald van Vollenhoven, rheumatologist and head of the Department of Rheumatology at the Amsterdam UMC in Amsterdam, the Netherlands. And having been at the ACR Convergence Congress of 2021, it was my pleasure to be able to discuss some new data on upadacitinib. Upadacitinib, of course, is a JAK inhibitor approved for the treatment of rheumatoid arthritis. And one of the interesting pieces of data, of course, on this drug is also how long the response can be sustained. And we had the opportunity to analyze that based on one of the pivotal phase 3 trials that had previously been done and reported about upadacitinib. I did this work on behalf of a group of investigators internationally, and of course with support from the sponsor of upadacitinib, AbbVie. Now, the objective was to see if patients who had responded very well initially would also maintain that response, which is of course what the patient wants. And so we took data from the Select Beyond clinical trial, and that's the one where patients could participate if they had rheumatoid arthritis, which was active, and they had already been treated with a biological, usually an anti-TNF biological, and they had not had the sufficient response. So that's a pretty tough patient population to treat, and as was published already several years ago, in that patient population, upadacitinib was clearly superior to a placebo and achieved good results in very many patients. That was part of the reason it has been approved by the FDA, the EMA, and other regulatory authorities. So these patients were also followed more longitudinally, and then you can ask the question, if a patient does achieve that good response, do they then also maintain it? And that, of course, for the patient, very important. So we looked at 4 different good kinds of responses. The best response is undoubtedly the remission, according to a tough remission criterion. And the one we chose for this analysis was the CDAI, the Clinical Disease Activity Index. And if you have a remission on the Clinical Disease Activity Index, it has to be less than 2.8. That's a very good result. Not many patients achieve it though, but it's a very, very low level remission with a high bar, low percentage that achieve it, but it is very good. That was achieved by 34% of the patients in this trial. And we also looked at the remission that is sometimes called a remission, but sometimes not, according to the DAS28. And people have criticized it because it's a bit too lenient. That is achieved by more patients. In this case, 70%. So you can say it's not truly a remission, but that is also a good outcome for sure. Then we also looked at the CDAI, which I just mentioned for the remission. You can also say, well, how about the CDAI less than 10? That's a low disease activity. Or you can say the DAS28 less than 3.2, also a low disease activity. So there are different ways of looking at what a good outcome is for the patient, but we're going to look at all 4, and then you can pick your choice. So these were achieved by the patients to a variable degree. And now the question is, if they achieve it once, do they maintain it? Now for this, we generated Kaplan-Meier curves, and the Kaplan-Meier curves actually show that some patients maintain it and others do not, which is what you expect. How many do achieve it and maintain it? Well, it depends a little bit on which of these outcomes you look at. The best case, it's about 60%, but the least good case, just a little under 40%. So you may say that, well, okay, well, it's good for the patients who maintain it, but I would have hoped that maybe more patients can maintain it. And so that's the typical glass full, glass half full, half empty kind of discussion. So we decided to look a little bit further and say, okay, so what exactly is going on? And now I have 2 little bits of good news. If you say that patients losing this response is bad news, then we do actually also have good news for those patients. Because in a separate analysis, we showed that if you, for example, achieve the CDAI remission, this is a very good outcome, right? And then you say, okay, but some of these patients lose that outcome again. It turns out that the vast majority of those who lose it, actually, they go to low disease activity. They don't go to high disease activity. They don't go to moderate, they go to low. So even though they don't technically still have a remission, they're still doing pretty well. Or you can say the same thing, if you have achieved low disease activity, most patients do actually maintain that. Some actually get better and go to remission. And the ones who do not maintain low disease activity end up with moderate. So a slight worsening could be the explanation of that. it turns out that even if you lose that response you had initially, you don't lose it by much. There is a little up and down, of course, in all of these measures. So that's part of what mitigates the original result, that some people lose the response. And the other thing is, and this is also something you could wonder, if the patient has had, say, a remission, and then a few months later you check and, oh, they lost the remission. But they could recapture it also. And we looked at that as well. And it turns out that of those patients who have achieved one of these good outcomes, then on the next assessment, they lost it. Then it turns out that half of those actually regain it. So clearly, some patients end up very close to the cutoffs, and they could go up and down a little bit. But overall, I think we can conclude that for patients who are, a tough patient population because they have failed biologicals, they're now treated with the JAK inhibitor upadacitinib. If they achieve a good response, which many patients did, then also many of those will maintain that very good response. And even if they do not, usually we're just looking at a slightly less good situation, a slight worsening, but we're also seeing patients recapture that good response eventually. So I think in many ways, these data support the fact that upadacitinib can achieve a very good result for many patients, and there is a good duration and a good longitudinal follow-up, saying that this is also for the long term a useful, a good treatment for patients with rheumatoid arthritis. Thank you very much.
Thanks for joining us for this edition of ACR Highlights. I hope you enjoyed them. Make sure to subscribe to CSF podcasts on Apple, SoundCloud, or wherever you get your podcasts, so you don't miss out on our Congress content or any of our other usual monthly content. You can also visit the CSF webpage at cytokinesignaling.com, where you can access a whole range of resources, from monthly slide summaries of latest papers to accredited CME courses and more content as well. Thanks for listening.